morning. I'm Dr. Brian Kaufman. I'm a family doctor, a doctor turned patient here at ASCO 2013. It's my pleasure to be with my friend Dr. Bill Wierda. You want to introduce yourself, Bill?
Sure, I'm Bill Wierda. I'm a professor of medicine at the MD Anderson Cancer Center and the Center Medical Director for Leukemia and the section head for CLL.
So, Bill, I know you've done a lot of work in immunotherapies, and I'm wondering if you could just take us a step back and explain a little bit about the difference between passive and active immunity and how that might relate to CLL in particular.
Well, so generally speaking, the difference between active and passive, as you probably know, is that in an active immune response or an active immune therapy, you're trying to generate an immune response against a specific antigen or protein. And we've done a number of clinical trials with vaccination strategies for CLL. I was involved with Tom Kipps at UCSD when I was a fellow, and then subsequently with a strategy where CLL cells were modified to become immunogenic, and those were reinfused back. Patients' own CLL cells were modified to become immunogenic, and those were infused back into patients as a way to generate and stimulate their own immune system to react against the leukemia cells. So you can use a patient's own leukemia cells as an active immune strategy. You can use protein antigen as an active immune strategy, and there are examples for that. Other investigators have used plasmids, DNA, circular DNA that's injected as a vaccine for leukemia, particularly CLL. By and large, those strategies have been challenged, and there hasn't been really anything that's moved forward in the clinic for general use for active vaccine strategies when we're talking about simply vaccines. There was a company called Genotope that had generated an idiotype vaccine, and we were doing a clinical trial with that.
So idiotype means individualized for each person, is that?
Right, based on a specific sequence in each individual patient's CLL cells. So those strategies have been, we've been working on those for many years, but they've not been really productive in terms of moving forward in the clinic and in large clinical trials. Passive immunization or passive immunotherapy refers to treating a patient with an agent, so for example a monoclonal antibody, where you're giving them the monoclonal antibody and that is generating an immune reaction against the leukemia cells. So while a monoclonal antibody therapy may be directed against a specific protein, it's still an active process because you're providing that as an infusion to the patients.
So an example would be rituximab would be the main example.
Rituximab, alemtuzumab, the monoclonal antibody therapies are examples of passive immunotherapy.
So one of the problems with CLL is it's a cancer of the immune system. Is that why it's so difficult to enlist the immune system? Is that the problem?
Absolutely. So with CLL, unlike other cancers, there are a number of abnormalities or derangements that occur in the immune system. So one example is in patients who develop the disease and who are previously untreated, we see a gradual decline in their antibody levels in their blood. And this is because the CLL cells are present and affect the immune system and suppress the immune system and dysregulate the immune system. So we see this gradual hypogammaglobulinemia or reduction in antibody levels. That in and of itself is immunosuppressive and will oftentimes lead to infection. And we try to replace that sometimes in patients who have significant infections by giving them IVIG infusions. And then we've done other studies looking at T-cell function and have clearly shown that there are abnormalities in both numbers of T cells and function of T cells. And we've done work trying to get at what the mechanisms for those abnormalities are and trying to correct those abnormalities, taking T cells out of the disruptive environment of the CLL patient, and we can grow them in the lab. We know we can grow them. We know we can get them out of this stunned, dysfunctional state by growing them outside of the patient and in the lab. And we've done some clinical trials reinfusing those patients as a strategy to immune reconstitute patients. And so one of my areas of interest has been the CAR T development.
And that's what you're talking about now, CAR T? Or?
Exactly, no.
Okay.
So CAR T is a little bit different of a strategy, but another area of interest and effort that I'm working on is immune reconstitution and getting at some of the mechanisms for immune dysregulation and strategies that we can use to correct the immune dysregulation. And that's, again, aside from the directed CAR T cell therapy. I think they're related because generally speaking, the way the CAR T cells work is that you take a T cell from a patient in the laboratory, put a receptor in it that allows it to recognize and react against the leukemia cells. Once that gene is expressed and in the T cells, you reinfuse those T cells back into a patient. They work well in the laboratory. They also, early investigations in Carl June and Porter's group
that was the
have shown
UPenn stuff
activity.
that was made New England Journal and was big news.
They work in patients, but I'm still worried that there are CLL cells there and that they may disrupt the function and may affect the function of those CAR T cells. And really what you want is not just something that works right away, but you want something that there will be persistent activity and persistent elimination of any CLL cells that may still be left over.
Now, haven't there been issues with resistance developing in some of these? I'm not sure if it's CLL. I think it's some of the acute leukemias.
So there is report that of an immune escape mechanism in the CAR T cell strategy with this. So the CAR Ts in the UPenn experience are directed against an antigen called CD19, which is on CLL cells. It's on some ALL cells. It's on normal B cells. And what that group has shown is that there have been patients, I think one patient for sure, who have had growth of their leukemia because they lose that antigen, that the cells have lost the antigen that targets the T cells. So that's one potential immune mechanism. I'm sure there are others. As we treat more patients and we get more experience, I think we'll learn more about what those mechanisms will be.
Is there a role for immune modulating drugs like lenalidomide or thalidomide or some of the newer ones in what you're talking about?
For sure. So those are things that I'm interested in further investigating. And again, that's getting at how do you correct the immune dysfunction which is brought about by the environment in a CLL patient where there are CLL cells there that disrupt immune function. Lenalidomide has been one agent that's been studied. There are features of lenalidomide that help to correct some of the immune dysregulation and dysregulatory, the features that dysregulate the immune function. Features like lenalidomide will correct and allow T cells to synapse or form a bond with CLL cells and other cells of the immune system, and that may be one way that lenalidomide corrects or allows immune activation or reactivation in patients who have been treated with lenalidomide.
So last question, if you're a patient and you're interested, there's all this buzz about CAR T therapy, immune therapy, what advice would you give? What trials are there? What things can people look at if they need therapy tomorrow, if they need therapy in 6 months from now? What would you be telling a patient who came to see you in consultation about this?
Right, so the CAR T cell therapy is very early in development, and I've had a lot of patients come to me and talk to me in clinic and ask me about going on CAR T cells. There's a lot of work still that we need to do with CAR T development. It needs to be done safely. Probably the easiest way to find CAR T cell clinical trials is by going on to clinicaltrials.gov and looking to see. That is a very well maintained, up-to-date database that you can search for clinical trials that are open and available, and there are a number of ways that you can search that database for potential opportunities and options. Again, the CAR T cell strategies are very early in development. Most of the clinical trials that will be open, that will enroll patients with CAR T cell therapy, are going to be patients who have failed the standard therapy. So it's going to be something that initially early is only going to be available to people who don't have other standard options available to them. So, but certainly I'm very committed to development of CAR T cell therapy. I think it's it's going to be a viable treatment option. We need to be able to do it safe, and we need to learn about how these cells work and how to best manipulate and optimize the therapy. I'm very optimistic about that strategy, as well as strategies to immune reconstitute patients with CLL, because as you know, it's not just the leukemia that's present that's the problem for patients with CLL. It's the underlying immune dysregulation and risk for infection.
Right, and secondary cancers.
And secondary cancers.
Yeah.
Absolutely.